esteemed members of the Pharmaceutical Society of Kenya, seniors, respected seniors who are joining us this wonderful evening, esteemed colleagues of the Pharmaceutical Society of Kenya, and other healthcare allied professionals who are joining us for this wonderful evening. You're much welcome to today's webinar. Today's webinar is in partnership with CC Pharmaceuticals. It's a new approach in medical management of premature ejaculation. And the speaker for today is going to be Dr. James A. Ikol, a consultant surgeon and a urologist from Kenyatta National Hospital with a private practice at Fortis Healthcare Center. Probably we are now at 300 attendees. So probably I wish to ask us all to in the chat box kindly type from which the year that you joined PSK. I want to know the year that you joined PSK for the PSK members. For the non-PSK members, which year did you learn about PSK? That's all I want. Probably the region you come from and the year or when you joined PSK. Kindly, as we are already at 300. So I will go at in 1 minute on the chat box. Kindly, Asante. So good evening once again, ladies and gentlemen. Good evening, respected seniors of the Pharmaceutical Society of Kenya. Good evening, esteemed colleague of the Pharmaceutical Society of Kenya. And good evening, our guests for today and other allied healthcare professionals. Welcome to today's meeting. Today's meeting is on new approach in medical management of premature ejaculation. It is in partnership with CC Pharmaceuticals. The speaker for today is none other than Dr. James A. Ikol. Probably for the respected seniors, it's somebody you went to class with. Probably you'll be hearing from him today. Just before we begin, a few ground rules and announcements. Thank you for participating in this session. All participants are muted during the entire course of this session. Please ask your questions via the Q&A tab at the bottom of your window. Questions shall be addressed by presenters on the Q&A tab and live. For PSK members, if not already done so, please subscribe on PPB portal for the meeting today so that you can get your CPD points. CPD points will only be awarded to paid up members. For KPA members, the attendance list shall be shared with the officials for awarding of CPD points. Just a point to note is that this session is being recorded and will be made available on PSK's YouTube page. For those who are asking which and where this meeting is available, the meeting is available on page 6. The meeting is available on page 6. Below there, you'll find a new approach in medical management of premature ejaculation. The meeting is available on page 6. Thank you. Without further much ado, this is our agenda for today. Welcome and opening remarks. I will be the facilitator. Presentation by our wonderful speaker, and the Q&A section by myself. And after that, we're going to have a close of the meeting. So ladies and gentlemen, without further much ado, allow me to probably allow the speaker for today to share his screen. Dr. Ikol, are you with me?
Yes, thanks, I'm with you.
Yes, Dr. I now give you permission to probably share your screen.
Okay, you need to stop sharing yours.
I've stopped sharing, Dr.
Okay, where did it go? Where did you take it? Okay.
As Dr. Ikol joins us, Dr. Ikol is a consultant surgeon and urologist with an MD-CHB from University of Nairobi, M.Med. ASEA Urology. Dr. Karibu sana to today's meeting. You're much welcome, and I give you the chance now, Dr. Take it over, Dr.
Thank you very much, Gitao. And thank you for having me for this session. Thank you very much, Sisi. I liked your first 2 slides. Number 1 showed a more handsome and younger me. And then, of course, slide number 2 of ground rules, which was very good. I'm a little bit dark, so I may as well stop sharing my video. Is that okay? Well, let
It's
me
okay,
just...
Daktari. It is okay, Daktari.
Okay, so good. So we are talking about premature ejaculation. This is not the conventional audience I usually speak with. So I am going to share my thoughts on premature ejaculation from the perspective of a urologist. So what I've prepared for you today is we are going to look through an introduction, the definitions, epidemiology, a classification of premature ejaculation, which most people my age, the first 4 points may not really be interested in, actually 5, and then probably more interested in the last point, which is management tools for premature ejaculation. So I will start by posing a question. Does premature ejaculation exist, or is it a myth? Because you will note that ejaculation depends on what we define it. So prematurity itself is more based on a lot of cultural issues, a lot of practices within societies, a lot of practices within different age groups. When you look at mammals generally, the purpose of ejaculation was for procreation. So it was therefore imperative that the male would ejaculate as quickly as possible so that he can have coitus with as many female partners as possible for the purposes of spreading his genetic material. So rapid ejaculation, therefore, enhanced the ability of this particular mammalian to procreate with multiple partners. However, for us human beings, aside from reproduction, premature ejaculation, apart from reproduction, sexual function has been found to improve the quality of life and then improve our general well-being. If you look through a number of materials on the net or journals, you will find that there are a number of benefits of having sex which are indicated in those reading areas. I don't know why my screen is freezing. Well, my screen is freezing. I want to do something here.
Hey, Daktari, stop slideshow, then go back again, or press next on your screen, Daktari. Is a next, yes?
Okay, good. So, yeah, now I think I got it now. So basically, what are we looking at? In the sexual act, we'll find that the sexual act is a very complex psychobiological response, which is influenced by very, very many factors. There are biological factors, among them sexual maturity, an interplay of various hormones, especially testosterone, sexual orientation on those who believe in a different gender or different sexual orientations. Then you have a lot of psychological interplay also, which all play around the stimulating condition. And some of these stimulating conditions are sexual fantasies, the member of the opposite gender, the level of emotional bonding between the sexual partners. Aside from that, there are a lot of socio-cultural issues that will affect sexual motivation. One of them is sexual knowledge. And then also the values which have been impacted on us by our families, our societies, our religious groups, and many other individuals. Peer pressures also will kind of impact on our sexual motivation. So when we look at the physiology of sex, as described by Masters and Johnson in 1996, there is a response to the sexual cycle, which starts with excitement, in which case in the male, the penis enlarges. And this is the time when the penis is able to penetrate into the vagina. And then there is a plateau phase where the excitement peaks, and then we have the orgasm phase, which is associated with sexual release and ejaculation for the male, and thereafter a resolution phase or a refractory resolution phase where we get detumescence in the male, and or in the female, you have the sexual organs generally release blood. The refractory phase varies between males and females, so that males have a longer refractory phase, which can last for anything between 30 minutes and a few hours, even 24 to 48 hours, in which case, therefore, they are not able to achieve a proper orgasm or ejaculate again, whereas women have a shorter refractory phase and therefore can engage in the sexual act soon after the first one. So what is premature ejaculation? If we agree that premature ejaculation indeed exists, then what is premature ejaculation? From a urology perspective, we use the International Society of Sexual Medicine definition of premature ejaculation, where the following have to be met. One, has to have an ejaculation that is always or nearly always occurring prior to 1 minute. If it is 1 minute following vaginal penetration, that is in lifelong premature ejaculation, or less than 3 minutes in acquired premature ejaculation. During this time also, you can define an inability to delay ejaculation on all or nearly all vaginal penetrations, which is basically a loss of control of ejaculation. And accompanied with it, there'll be negative personal consequences such as distress, bother, frustration, and avoidance of sexual intimacy among these persons. The mental health practitioners have a different definition, which is actually the first point up there, which was described by the Diagnostic and Statistical Manual of Mental Disorders 5. In this, they look at various points: a consistent ejaculation within 1 minute or less of vaginal penetration, over the given duration of at least 6 months, and in experienced persons, this happens 75 to 10% of the time, and then also considers the mental state of the individual in that it causes distress. And yeah, so basically those are factors which are described by the mental health practitioners. The prevalence of premature ejaculation varies worldwide depending on what parameters we use to measure it. Suffice it to say that generally it is agreed that the prevalence is around 20 to 30%, and various authors have come up with various levels in different countries. Closer home, a research carried out in Kumasi, Ghana, by Amidu and his colleagues, published in 2010, found a prevalence of around 64.7, which is almost twice what was described in other studies. So the question therefore we ask is premature ejaculation very high in Africans? Maybe not, maybe yes. But just looking at this paper by Amidu and his colleagues, we note that, which was published in 2010 in the International Journal of Impotence and Research, we note that the definition for premature ejaculation was not clear in their study. And then the perceived intravaginal ejaculatory latency time in their study was actually 3 times what is defined as normal. They looked at the perceived intravaginal ejaculatory lateral time among the population in Kumasi is 7 to 25 minutes. However, internationally agreed, it is thought that men should last any time between 3 to 10 minutes. So you can see, therefore, his cutoff was pretty high. No wonder then, maybe he had very high numbers. Looking at his paper also, we find that he noted a very high level of infrequency. That means partner contact was low. And then there was also a high level of non-communication, which basically you may want to interpret as a poor mental health kind of situation. But again, subsequently in a paper he published again 4 years later, still showed a very high level of premature ejaculation associated with erectile dysfunction at around 70%. To be able to manage any condition, we have to be able to classify it. And indeed, the International Society of Sexual Medicine came up with a classification of premature ejaculation, classifying it as either lifelong or acquired. And lifelong is sometimes referred to as primary or sometimes referred to as secondary. In this, when you look at the intravaginal ejaculatory latency time, lifelong premature ejaculation will be less than 1 minute. And in such persons, this has been occurring since their first sexual encounter. Statistically, you find the prevalence of lifelong premature ejaculation is low, and these persons typically have poor or no ejaculatory control. The etiology is thought to be genetic or neurobiological, and considering that is a genetic or neurobiological disorder, then the mainstay of treatment, therefore, is going to be pharmacotherapy plus or minus psychotherapy. When you look at acquired or secondary premature ejaculation, in these particular persons, these are persons who have had normal ejaculation before, but along the way, they persistently have an intravaginal latency time of less than 3 minutes. The onset can occur anytime at the man's life. The prevalence is low. In the terms of control of ejaculation, they may or may not have ability to control the ejaculation, and there are various etiological factors attributed to acquired premature ejaculation. Among them, urological conditions like erectile dysfunction, infections of the prostate and the urethra, hormonal conditions, those which have been mentioned are hyperthyroidism, and indeed psychological and relationship problems. The treatment, therefore, would require that we address, first of all, the underlying condition, and then look at pharmacotherapy and psychotherapy thereafter, education. Further, you can classify premature ejaculation into variable and subjective. This is based on mental health disorders. So in the variable premature ejaculation, the latency time may be short or normal, and then it is inconsistent. Sometimes it's there, sometimes it's not. And it can occur at any time in a man's life. The prevalence is high. Ejaculatory control may be normal or low. The etiology varies, and indeed it is thought that it's a normal variance of what all men go through. We have variable premature ejaculation at different states of our mind and stages in our lives. So in such a situation, therefore, since it is more of a mental and transient condition, then treatment mainly focuses on reassurance, education, and maybe behavioral therapy. The one that is disturbing us right now as a family of healthcare givers or urologists or sexologists is the subjective premature ejaculation. In these particular persons, the intravaginal latency time is normal or may even be prolonged, but the person perceives that they have premature ejaculation. The prevalence of this particular condition is pretty high. The person has ejaculatory control and or may have a diminished ejaculatory control. The main etiology is a psychological preoccupation with what is imagined as rapid ejaculation. And this is a common situation now we are seeing basically in our college going population. And for this, the mainstay, therefore, of treatment is going to be psychotherapy, reassurance, sex education, to be able to manage their expectations. When we look at pathological premature ejaculation, there are various hypotheses which have been forwarded as possible causes. There is the psychological hypothesis where it is thought premature ejaculation is caused by a mental or an unstable mental condition where one has performance anxiety or any other anxiety for that matter. Aside from that, there is also the hypothesis of penile hypersensitivity. And in this hypothesis, it is premature ejaculation is believed to be caused by a high number of branches of the dorsal penile nerve in the patients. We have two dorsal penile nerves, right and left, and then these undergo branching. Typically, one is going to have two branches. In 2009, Zhang and his colleagues published their findings in the Chinese medical journal, and they looked at 38 autopsy specimens in persons with premature ejaculation. And the conclusion was that persons with primary premature ejaculation had typically more branches, around 4 branches of the dorsal penile nerve, which is basically 2 times, at least 2 times what the person with no premature ejaculation really had. That is the basis of this penile hypersensitivity theory. The other theory for which a lot of our treatments are based on now is the neurological hypothesis theory. It is good to note that there are various neurotransmitters involved in the control of ejaculation. Important neurotransmitters have been serotonin, dopamine, oxytocin, GABA, acetylcholine, nitric oxide, norepinephrine. So it is the neurological hypothesis postulates that a dysfunction in the receptors for neurotransmission is responsible for premature ejaculation. You can stop me anywhere if you have a question or raise your question in the chat box. When it comes to the ejaculatory reflex, the ejaculatory reflex begins with arousal and sensations on the glans penis. These are transmitted through the pudendal nerve afferents to the S1, S2, and S3 segments. The information is integrated at spinal level, and then the efferents come through T10 to L2 sympathetic centers, which are going to innervate the seminal vesicles and the prostate to promote emission of sperm from the seminal vesicles and the prostate. Similarly, you have efferents from somatic efferents from S1, S2, and S3 through the pudendal nerve to the bulbospongius and pelvic floor muscles, causing them to rhythmically contract and therefore expelling the semen. There is parasympathetic innervation also from S1, S2, and S3 to the prostate and the seminal vesicles. So this is basically the ejaculatory reflex. What we need to know is that this is under influence from central centers in the brain, which are mainly serotogenic and dopaminergic neurons, which are going to either inhibit or remove inhibition in the spinal ejaculation center. The risk factors for premature ejaculation from a clinical perspective: 1, low education. Generally, you cannot do what you do not know. So if one does not know how to have sexual intercourse, then generally they are going to have a problem with sexual intercourse. Various authors have also indicated that there is a higher prevalence of premature ejaculation in Africans, Hispanics, and Arabs. No reasons have been given. A genetic predisposition has also been indicated. Aside from that, closer back home, prostatic inflammation is a common situation causing premature ejaculation. And indeed, in our practices, we find patients coming who have lower urinary tract symptoms, and indeed, they will also complain of premature ejaculation. In populations with too much food, obesity is one of the risk factors, thyroid hormone disorders, and we must not forget emotional disorders and traumatic sexual experiences, which are going to affect a person's emotional stability. Erectile dysfunction and premature ejaculation are interrelated, and you will find one will make the other worse. So at any one time, it is not uncommon to find the male with premature ejaculation also having an element of erectile dysfunction. It is postulated that this happens, this coexists in around 70 to 60% of the people with premature ejaculation. How then do we evaluate somebody with premature ejaculation? This slide is taken from the European Association of Urology guidelines. And the guideline states that, like all medical conditions, one has to take proper medical and sexual history. And this history should include an assessment of intravaginal ejaculatory latency time. This time can be measured by a self-estimate or estimate by partner. One should also be able to evaluate the level of perceived control and the amount of distress and interpersonal difficulty this condition is causing to the individual and indeed to the couple. A physical examination is important in the initial assessment, and in this physical examination, one really wants to identify any anatomical abnormalities that may be associated with any type of sexual dysfunction. It is not mandatory to perform any laboratory or imaging studies unless there is an indication based on the history and the physical examination. While assessing intravaginal ejaculatory latency time, must one use a stopwatch or not? The recommendation is that it is not necessary to use a stopwatch. How useful are patient-reported outcome reports? The EAU guidelines say they may not be very useful. As part of assessing the premature ejaculation and indeed evaluating treatment, it is good to have validated questionnaires. Those that have been thought to be useful or in clinical practice are the Premature Ejaculation Diagnostic Tool. And this looks at, there are 5 questions asked, and it's a good screening questionnaire which gives us cutoff values. The drawback is that it may not correspond with self-report of premature ejaculation. Another very good one is the Arab Index of Premature Ejaculation, which looks at 7 parameters. This particular one is able to assess a person's desire, a person's erection hardness. It also takes into account the ejaculatory, intravaginal ejaculatory latency time, the control of ejaculation, and the satisfaction both in the partner and self. These other premature ejaculation profile and interprofessional education have not been shown to correlate well with, they have not been shown to be very useful in clinical practice. The management principles of premature ejaculation require that one will define the type of premature ejaculation, right? Whether it's lifelong or acquired, primary or secondary, which is the same, or is it subjective or variable premature ejaculation? We need to be able to establish the patient's expectations. You see, in the Ghanaian study, the expectation was that a man should last 25 minutes. International literature says if you last 10 minutes, then you are very, very okay. Even 3 minutes is allowed. So we need to be able to establish and indeed manage the patient's expectations. We will have to treat any underlying conditions, and this have been mentioned in an earlier slide, but allow me to repeat: erectile dysfunction, lower urinary tract symptoms, infections of the prostate and the urethra, anxiety or mental disorders, hyperthyroidism, or any other endocrine disorders. The mainstays of treatment are going to be sexology treatment, and then we are going to have pharmacotherapy. When we look at pharmacotherapy, they are both approved and off-label formulations for premature ejaculation, and this can come as on-demand or daily dosing formulations. Many authors believe combination treatment works best where you combine pharmacotherapy and sexology treatment. So what does the sexologist do? I was very ignorant of sexologists, and indeed I didn't know they existed in this country until we had a conference on sexual medicine that is around 3 or 4 years ago, and I was surprised we have very many sexologists in this country. And I must attest that involving a sexologist in the management of premature ejaculation is very, very useful. They have really enhanced my practice. What do they do? One, in psychotherapy, they manage all the psychological etiologies. They're able to counsel the person. They're able to manage the distress in the individual who has any form of sexual dysfunction. And indeed, in subjective premature ejaculation, they're actually the mainstay of treatment is psychotherapy. When it comes to behavioral therapy, there are a number of techniques they are going to teach. Start-stop techniques, the squeeze technique, and censored focus. All these techniques basically aim to attenuate the arousal, allow one to have control of the arousal so that the arousal level is dampened and therefore an ejaculation is not triggered. Some people have advocated for precoital masturbation, and what they basically indicate is that precoital masturbation also attenuates the arousal level because one will have already ejaculated, and then one after ejaculation, then in the subsequent coitus, then the arousal level will have been dampened. There is a drawback to this, however, because what we have noted in our practices is that men who masturbate a lot present with a lot of sexual dysfunction when now they get into penovaginal intercourse. Some individuals have advocated for the use of multiple condoms. I don't know how many men will want to do this, but generally the use of multiple condoms also dampens the arousal. When we look at pharmacotherapy, what has been available to us, we have topical anesthetics where these are applied on the glans penis for the purposes of reducing sensitivity of the glans penis. You remember in the ejaculation reflex, we had arousal being transmitted to the spinal center. So if you dampen this, if you reduce sensitivity of the glands, then that is going to allow one to have an improvement of intravaginal ejaculatory latency time to around 5.6 to 6.3 minutes, depending on the anesthetic you use. What is the drawback? Some authors, indeed, let me mention that this topical anesthetics can be available as creams or gels, and they can also be available as sprays. When you look at creams and gels may be a little bit cumbersome to handle. Aside from that, it may require that one has to wear a condom. And in some situations, one will require to wash off the cream before engaging in sexual intercourse. So all this kind of affects spontaneity of intercourse. Suppose you don't wash off a cream or aerosol that is supposed to be washed off, then one is going to have partner hypoanesthesia. So you can imagine a situation where your partner is telling you, boss, I cannot feel you, okay? That also is going to dampen one's spirit. Another drawback of topical local anesthetic is that timing is key. If you apply it too early, then you are going to lose sensation, you're going to lose arousal, and therefore you end up with an erectile dysfunction because there is no sensation anymore to get the flag up. SSRI inhibitors are a mainstay now of the pharmacotherapeutic armamentarium we have for the management of premature ejaculation. We have on-demand medications like dapagliflozin and daily dosing medications like paroxetine and others. What happens is that the advantage of dapagliflozin over these others is that it has a short half-life, and the peak concentration is achieved very fast compared with the others. This in an hour, these others in around five hours or so. The half-life also for dapagliflozin is much shorter. These others having a very longer half-life. So what does that mean? Therefore, the non-dapagliflozin SSRIs would require or are best taken as a daily dose, while dapagliflozin is best taken as an on-demand dose. The side effects of this, of course, are nausea, diarrhea, headache, and dizziness, which are all dose dependent. Then we have our good old friend tramadol, which is a medicine that is commonly abused by many individuals. The mechanism of action is that it will inhibit 5-HT reuptake as well, and it will improve the intravaginal ejaculatory latency time to around 3.3 to around 5.6 minutes. The side effects of tramadol are known, aside from, of course, the risk of addiction. The role of PDE5 inhibitors is also being evaluated, and it has been shown that especially in those persons who have concomitant erectile dysfunction, they improve the latency time to around 3.9 minutes for sildenafil and 6.5 for others. The side effects is that one can get a headache, flushing. It is good to note that a combination of PD5 and dapagliflozin has also been found to improve sexual function and indeed the latency time. There are novel agents which are used for managing premature, which are not used or which are being investigated for the management of premature ejaculation. For our purposes, I've circled these alpha blockers. And basically what is happening is that we are taking advantage of, or the authors or the researchers are taking advantage of the side effects of alpha blockers, tamsulosin, terazosin, silodosin, among others, because these alpha blockers generally are known to relax blood and neck smooth muscle and also inhibit seminal emission. So because of that, therefore, their side effects is to cause generally an ejaculatory dysfunction. So researchers are working on it to see whether it can be used for managing premature ejaculation as well. This is basically an area where PSK and cows can actually come together and do a research of our own so that we see whether we can exploit this for management of premature ejaculation in our patients locally. Botulinum A toxin has also been shown to be very promising, and this is injected to the bulbospongiosus muscle. So it blocks the neurotransmission and therefore is thought to help in inhibiting expulsion of semen. Unfortunately, this injection has to be given every 21 days. I don't know how many of us will be happy to go for a 21-day injection. Another area where PSK and cows can actually work on is on the use of Oxysorcian Antagonists. Okay, we can also look at investigating oxytocin antagonists because, like I had shown in a slide earlier, oxytocin promotes ejaculation. So if you block oxytocin, then we are going to delay ejaculation. There are other forms of ejaculatory dysfunction, and I believe this may come in the question and answer time. In the question and answer time, and some of the problems we can have are delayed ejaculation, in some situations, anejaculation, and in others, we have retrograde ejaculation. This is my favorite slide because Kenya is a beautiful country, and it also marks the end of my presentation. Thank you very much.
Thank you very much, Dr. Ikol, for the wonderful presentation. Our attendees for today, I know they're filling the Q&A part. Santeni, please continue putting your questions on the Q&A tab, and specifically the Q&A tab. Now, to probably in the reasons of time, to also allow CC Pharmaceuticals to also present, so that we're able to move next. Thank you very much, Dr. for the insightful and well researched presentation. Patrick?
Yes. Hello?
Perfect. It's well been seen.
All right.
Wonderful. Take it over.
Thank you. Thank you. Good evening, everyone. Yes, this is Patrick. My name is Patrick from CC Pharmaceuticals, and I'll take you through who CC is and the product that we have for premature ejaculation. So I just go straight to the company profile. So my names are Patrick Minor, as you can see. And who are we? CC Pharmaceuticals is an importer, distributor, and marketer of pharmaceutical and skincare products. For those who don't know us, we were founded in 2006 with the aim of providing market leadership for innovative pharmaceutical, diagnostic, and healthcare products through our core pillars, which are the regulatory support, sales, marketing, and distribution. And what informs our identity as CC Pharmaceuticals? It's an indigenous African institution which leverages on local content in both East and West Africa to drive its commercial plans. So we operate in Kenya and in Ghana. We also continue to invest in the advancement and development of the African pharmaceutical industry. And also we see the regulator as an important partner in the business. We are a people-driven focus as the patient, customers, partners, and the staff members. Our vision is simple: to be a leading importer, distributor, and marketer of pharmaceutical and healthcare products. We have quite a wide range of products. We have the men's health, which is the Targentis 5, 20, Profertil for male subfertility, Dynamo Delay, which is the center of our discussion today, and Smooth Gel, which is our lubricating gel. Women's health, we have Ready Prerox for female sexual arousal disorder, Profertil female for female subfertility, menopause, and Cifrosat. We also have the Hilase, which is very important, it's a sunscreen, SPF 50. We have antibiotics, a range of antibiotics, which is Cefacla, We have Crawford 750, 500, and also the suspensions 125, 250 for RTIs, UTIs, skin and soft tissue infections, and of course, Physiology for surgical prophylaxis. We go straight to our topic of discussion today, as Dr. Ikol has given us a very good lecture about it. So we've got a product that takes care or gives a solution to the males who have premature ejaculation, and we call it Dynamo Delay. And Dynamo Delay, actually, the main symptoms for premature ejaculation, as Dr. has said, is short ejaculatory latency, often less than 3 minutes, and also the inability to delay ejaculation and penetration, which will lead to the distress, frustration, interpersonal difficulty, and also avoidance of sexual intimacy. The pathophysiology that Dr. has explained it very well is an abnormal autonomic reflex pathways for the ejaculatory process. It's very common, or it's a common male sexual disorder, because up to 70% of the males have experienced premature ejaculation. 20% of males aged between 18 and 59 years experience premature ejaculation regularly, and premature ejaculation has high comorbidity with erectile dysfunction and depression, as Dr. Ikol has said. How is the efficacy of Dynamo Delay? So the mode of action is that it reduces the peripheral stimulation and also increases the threshold of orgasm. It's clinically tested because 70% its effective has been proven, and also has significant improvement in IALT, intravaginal ejaculatory latency time score, ejaculatory control, and sexual satisfaction. This is in very many guidelines and also recommendations, like the US FDA in 2017, the guidelines, American Neurological Association, that was in 2010, and European Association of Urology 2016. They recommend the use of Dynamo Delay. So there is significant improvement in IALT, ejaculatory control, and sexual satisfaction. There is one study that has been done. It proves the efficacy of Dynamo Delay in combination with tadalafil once a day. It's proven that it is 85% effective. As you can see, there are quite a number of similarities and also differences. If you look at age, body mass index, intercourse per week, and IALT baseline, there was no significance between the three groups, which the group one, the patients were put on the Lidocaine spray, which is Dynamo Delay. Group two, they were put on tadalafil once a day. And the group three, the patients were put on Dynamo Delay and tadalafil 5 milligrams. As you can see, there was a great significance in terms of after 1 month of taking the either Lidocaine spray, Dynamo Delay, which is Dynamo Delay, the tadalafil 5 milligrams, and the combination. After 3 months, the significance was great because those who were on combination had 5.6 minutes improvement compared to the others. There was also five questionnaires that were used to measure the satisfaction score. Still, great improvement on the patients who are on, or the group that had both Dynamo Delay and tadalafil 5 milligrams. And the conclusion, Dynamo Delay and tadalafil once a day may offer synergistic effect in treatment of lifelong PE. Dynamo Delay and tadalafil OD may be an adjuvant treatment for erectile dysfunction and premature ejaculation. So what about the safety of Dynamo Delay? Lidocaine is a WHO essential medicine, so it's very safe. And it is non-irritating, allergy tested, approved for OTC use, FDA approved with long-term stability studies, low incidence of hypoesthesia, and minimum drug-to-drug interaction. It's very simple to use. Dosage, 3 to 5 sprays, 10 to 15 minutes before anticipated intimacy. Consistency or consistent metered spray, easy technique, fast acting 15 minutes and long lasting up to 3 hours. And as I can show you, this is how it looks like. It's Dynamo Delay is a spray, very easy to use, and it comes in a pack. This is how it looks like. Very affordable to the patients, and it has one tube has 270 sprays, and you do 3 to 5 sprays before intercourse, and you wait for 15 minutes. And it does not cause numbness to the partner because you wait for 15 minutes, and it is absorbed into the skin and therefore does not have those kind of problems. So what about the competition? Dynamo delay has competitors and SNRIs, as Dr. Ikol has said. So it has a superior ILT score improvement, better compliance, and less treatment emergent adverse events, nausea, diarrhea, dry mouth, and drowsiness. As you know, with NSRIs, quite a bit of side effects, and therefore you might only need to give it for a short period of time. So we have the safer dynamo delay. In conclusion, I can say that premature ejaculation dynamo delay is effective, safe, and simple. It has significant improvement in ILT, ejaculatory control, and sexual satisfaction. And that is the end of my presentation. I welcome any question as far as dynamo delay is concerned. For the others, Dr. Ikol is ready to answer all the questions. Thank you very much. Back to Dr. Ikol.
Thank you very much, Patrick. That's a wonderful, and thank you very much for taking us through probably even who CC is and probably try linking what Dr. Ikol has presented on and linking it with what CC is doing in that regards. So probably I know some questions will be coming in. So let me allow Patrick to first take a glass of water as we go to Dr. Ikol. Dr. Ikol, an anonymous person. This one is going to be hugely anonymous for today. An anonymous person is asking, is premature ejaculation a men's only problem?
Yeah, thank you very much for the questions. Maybe for those who posted the questions on the Q&A, I have been answering some of them. I don't know whether these answers are visible to everybody. The few questions have been answered. I think I've already answered 5. But anonymous attendee, yes, premature ejaculation is a men's only problem because it is only men who ejaculate. Females have orgasms, but they do not ejaculate. But that does not mean that there is no sexual dysfunction in females. There is sexual dysfunction in females. This mainly is in the realm of the gynecologists. They are the ones who see them. So probably I am not very competent to answer very well on female sexual dysfunction.
Thank you very much, Dr. Ikol. So probably let me go through the questions that you've already answered so that our members are not, we don't have a repetition. So kindly clarify the difference in refractory periods in males and females. The response is male have a longer refractory period, hence take longer to restart.
I think I answered that, but let me repeat and say the refractory period is basically the time it takes for one to be able to restart after an encounter, after an orgasm. Most people will say that the trouble with men, once they have a good orgasm, they go to sleep, right? In what some people call postcoital malaise. That is part of the refractory period. It is not that the man is lazy, it's just the refractory period that he is in. And during that time, however much you try, it is unlikely that this man is going to get an erection again, right? So in our practices, we hear, but he has just done it, right? So give him time, give the physiology to resettle, and then he can wake up again. Unfortunately, in some individuals, the refractory period can last a whole day. So that means this particular person will not be able to get a proper erection and will not be able to engage in sexual intercourse or penetrative intercourse for that time he is in the refractory period. Women, on the other hand, have a very short refractory period. So a woman can receive you even 2 minutes after the last one. Thank you.
Asante Daktari. Thank you. You've even given us, you've given the male species who in this webinar today probably a good phrase to use. Akiulizwa mbona unalala maharaka? No, I'm on my refractory period. I am on my refractory period.
Hakuna excuses.
Hakuna excuses. So I am on my refractory period. So a question that has also been answered. Allow me, Dr. Ikol, to probably go through the questions that you have already answered, so that our members, so that we don't have repetition. Dr. Michael Mungoma, the PSK chairperson for the Education Committee, he comments, alcoholism has been proposed to affect sexual intercourse. Does it have a bearing to be or delayed? Is there an influence from MIRA from clinical experience? To our members, the response for Daktari says yes, falls in the drugs category. CAT is a good area to study. Anecdotal evidence suggests it's bad for sexual health. Okay, now the last answered question was by Chrysostom Wanjala. What could be a permanent pharmacological remedy for this condition? Daktari responded and said, depends on the cause. In those who with predisposing conditions, addressing these can be a permanent solution. Sexuality health is also good for long-term management. Probably one of the predisposing conditions, diabetes. If your sugars are well controlled, probably that answers a lot towards that. Is there a permanent solution to this problem? Again, that is the question above. So let me now go to the questions that have not been answered there. Also by Christos Tim Wanjala. What is the relationship between diabetics and the erectile dysfunction? Probably that's what he meant. Dr. probably just touch a little bit on that, as you had mentioned it in the presentation.
Yeah, thank you for that question. It is good to note that diabetes is one of these conditions that affects every cell in the body. With regard to sex per se, we need to understand that for one to be able to have sex, there has to be a general well-being of the body. A sick person cannot have sex because your faculties physiologically are directed towards healing you from the illness. So generally, for one to be able to have sex, we need proper body well-being just to get you in the mood. Okay, so that is one of the points about diabetes. Ill health causes stress. Ill health causes anxiety. It is good to note that anxiety is one of the worst situations for sexual health. An anxious man, either caused by illness or caused by an impending immediate mortgage payment, or indeed caused by a school fees bill, or a partner who is not his friend, is very anxious and mentally unsteady. That person will never get an erection. So illness itself is going to put one in a mental state where an erection is not possible. But calm down pathologically. Diabetes affects the blood vessels. Diabetes affects the nerves. We know that erectile function is an interplay between nerves, muscles, okay, and the blood vessels. If the blood supply is poor, you are not going to go get an engorged penis. Remember the slide I showed on the physiology of sex. The penis will not engorge because the blood vessels are not sending blood to the penis properly. Aside from that, to be able to get an erection, there has to be arousal. There has to be a stimulus. This stimulus is going to be transmitted through nerves, okay? Now, if the nerves are affected, as we know, diabetes does affect nerves, then the stimulus is going to be improper. And indeed, aside from the stimulus being affected, then the response also, the reflex, the efferent response also is an interaction of nervous function. So this is also going to be impaired. And then the other thing diabetes has been shown to affect is the smooth muscles around the blood vessels. In diabetics, you find there's smooth muscle rigidity. Because of that smooth muscle rigidity, Then we are going to have impaired vasodilatation and therefore impaired engorgement of the penis. So diabetes is one of these conditions where both in the short and the long term is going to affect all aspects of sexual function. Thank you.
Asante Daktari. So now we go to the question on the famous Mukombero and Kukumanga. Is there a role for herbal medicines? Probably, Patrick Minor, you say that you're researching to give African solutions. What is your contribution? These are both take for Dr. Ikol. Go first, then Patrick Minor contributes on what is their planned role on the herbal contribution.
Thank you very much. Herbals do work. Let me say, indeed, in one of the local anesthetics or local agent, there is a cream called SS, which is a purely herbal formulation, and it's actually is shown to improve the intravaginal ejaculatory latency time by around 6 to 10 minutes. The only drawback is that after you apply, you have to rush and wash before you use. And like I told you earlier, the drawback with the local anesthetic agents, if you apply it too early, then you affect arousal. Then it can lead to erectile dysfunction also. So that's one of the drawbacks of one of this herbal remedy called SS. Coming back home, Mukobero. Mukobero, I know there are some individuals who have done research on it. A paper was circulating among my peers, I think 3 or 4 months ago. I must admit I did not read the paper, but the conclusion was that it works. The question was, what dose? Nobody is clear on the dose. The other question was, how does it work? I'm not sure whether it was indicated in how it works, but I know the member who circulated this paper is actually a member of PSK. After this meeting, I'm going to ask him to remind me about that paper. The question is it just a psychological thing? It's actually a physiological thing. That is the question we could be asking. But as a psychological remedy, it works. As a physiological one, I am not sure. But again, this is an area where PSK and CAUS can come together and actually evaluate this particular product. It might put mine out of business.
Yes, Dr. Ali. Dr. Ali?
Yeah, how are you?
Yes, very fine. Yeah, I've been asked about CC Pharmaceuticals and what we are doing by saying that we have interest in coming up with solutions. And what I'd like to say is that, yes, that is true. We live by what we say. And I'll give an example that we are in collaboration with Medicals Africa with one of the local products that is locally developed, innovative product called Smugel, which is a lubricant. So if anybody has something that we can work together for the sake of looking for solution for our population, we are ready and willing. As I've said, Medicals Africa is local innovation with Smugel, and we distribute for them. So the floor is open. Whoever has anything that we can bring up and we partner, we are ready.
Asante for that. Members hope and attendees hope that is well understood. If you're willing to take Mukombero through the dossier process, Patrick is willing to be able to guide you through the other part of the distribution with the vision of being a lead distributor in the country.
But we have Targentis, sorry. We have Targentis for now. The dosage is known.
Oh, perfect. Where do you apply dynamo delay and both partners use? So combine that question with assuming one sprays dynamo delay during an erection and then waits for 10 minutes. I imagine the erection may have faded. That is to Patrick.
Yes, what I said is only the male partner. You spray it, you make sure that is the aerosol that is touching the glands and the shaft. you spray the shaft and the glands at the same time, and you wait for 15 minutes. So what happens is that you are active, or you can have your erection and it will be active for 3 hours. So it doesn't mean if you spray, if you have a strong erection for 15 minutes, you'll be able to wait. And still within 3 hours, if you are able to rise up to the occasion, you still be able to have a satisfactory, intimacy without having to get a premature ejaculation.
So this goes, now we go to Dr. Ikol. There are two questions for you, Dr. One is is a total negative feedback question. That's very informative indeed. How would you handle delayed ejaculation? Sasa kuna wale wanasema wanakaa sana. How do you handle that? The second question is, priapism is it a myth, or can it be one of the side effects of some of the above described medication? Go ahead, Dr.
Yeah, thank you very much. Delayed ejaculation, unfortunately, is not very, very common, occurring in a small percentage of the population. I must say that in the last 10 years of my practice, I've only seen one. And interestingly, that was, I think, sometime last year. But what are some of the causes of delayed ejaculation? Because we have to understand the causes so that we can be able to treat them. What I found in this particular person that I treated was that it was a psychogenic problem. What happens is that in persons who masturbate regularly, frequently, and aggressively, these persons have conditioned themselves to have a very high level of arousal to be able to ejaculate. Now, unfortunately, this level of arousal is not achieved during penovaginal intercourse. So because of that, therefore, the level of arousal does not peak in penovaginal intercourse. And in such a person, really, what would really need to do is more of sexology management in terms of sex, psychotherapy, and indeed behavioral therapy. The issue of penile hypersensitivity. Penile hypersensitivity can occur following various conditions, diabetes being one of them, nerve damage being another. The use of PDE5 inhibitors, and Maina has talked of tangentitis, long-term use of PDE5 inhibitors has been shown to improve this condition of penile hypersensitivity. Another is the use of shockwave treatment. Shockwave treatment applied on the gland is also been shown to improve. We must not forget the role drugs play in causing delayed ejaculation. And SRIs are some of them, tricyclic antidepressants are others, which actually will lead to the cause of delayed ejaculation. So of course, one has to weigh the benefits and the risks. Does one want mentally disorder managed, or does one want to have a normal erection and forget the mental disorder? Then of course, in persons with endocrine diseases, low testosterone has been shown to play a role, but you note with the low testosterone, there's probably not going to be an erection in the first place. So the issue of delayed erection, it is mentioned, but of course, in quotes. There are people who have had surgery in the penis or in the pelvis, bleeding, and indeed around the rectum and sigmoid colon. So that leads to an element of denervation. And with this denervation, then we must look at issues of shockwave treatment and vibratory treatment. Thank you very much.
Asante. Asante, Dr. Ikol, for your wonderful response. Now we move to Alexander Mushugia. So how does the user enjoy as when you use lidocaine, you get numb? since most of the premature ejaculation issues are mostly psychological, how do these medicines deal with psychology, or it's mostly physiology?
So because the problem is, finishing before you even start. I think you need the patient to be able to enjoy that longer duration. The numbness is not complete. You still have some sensation that can be able to give you some pressure. So you still can be able to enjoy, but you delay because you don't irrigate. You just spray 3 to 5 times. So it will be able to numb most of the nerves.
Right. So that question goes ahead.
Yes.
This question goes ahead with Dr. Senior respected member, Dr. Tom Sindani's question. Dynamo delay might still cause desensitization. Is there a problem if it is washed off before the sexual intercourse? Or would you advise so on its use?
You don't have to wash it, because once you wait for 15 minutes, it's absorbed. So not necessary that you have to wash it off.
Asante.
Yes.
So, asante. Dr. Ikol, there are 2 questions for you. Probably you may answer them concurrently. If a person has PE and ED, should you prioritize PE or ED? Would you recommend Vardenafil or use on hypertensive people for management? Secondly, Ephantas Loceno, in your practice, what's the prevalence of cardiological problems in PE? Dr. Ikol?
Okay, you asked if one has a PE and ED.
Yes.
Okay, that one, the recommendation generally is that we treat the ED first and see whether it controls the problem. Remember, I said earlier that ED itself can be a predisposing factor for premature ejaculation, because here is a man who knows he's not going to last long. So if you know you're not going to last long, then you may as well just do it quickly. So it goes there for that to help you not to have to do it quickly, then maybe can we give you a better erection? So the recommendation therefore is that let us manage the ED. If nothing improves, then let us put in some treatment for premature ejaculation as well. Suffice it to note that in the market, there are some people who are marketing a product which is a combination of sildenafil and naproxen. But whatever the case, ED first, because it may be the only problem. And we must never forget, I remember my year 3 lecture, my first year 3 lecture in pharmacology by the late Professor Ndele. The first thing he ever told us is medicine is a poison. So you must use medicines only when necessary. So therefore we aim to treat ED first.
Asante, asante. So what in your practice, what is the prevalence of cardiological problems in premature ejaculation?
You see, cardiological problems have various etiologies. The person with a mild cardiological issue caused by arteriosclerosis is going to have an element of arteriosclerosis, or diabetes is going to have an element of ED, and indeed an element of premature ejaculation. Those are easily managed. The trouble is the people with severe cardiological conditions, they may be too frail to be able to engage in sexual intercourse, but I must say never. In one situation, I came across an Italian man who had 4 penile prosthesis over time at the age of around 80, 90, and he had had 2 bypasses, coronary artery bypasses. He had had 3 of them. So we say never, even at 80, 90, despite having some of these conditions, we still need to do it. So we have to weigh the benefits and the risks, okay? And you must understand also that one does not necessarily have to ejaculate to get an orgasm. So maybe as one advances in age or pathology, you are probably more interested in the orgasm than the ejaculation per se. And probably that's the basis by which penile prosthesis work, because it's an unnatural erection, but at the end of the day, you have this feel good, feeling. Sorry for the repetitive grammar. Thank you.
Asante Daktari. So, a question asked earlier by Dr. Mora Kiangoi. Good evening, Doc. Could you speak to the possibilities of two areas bringing in PE, premature ejaculation, reduced exercise and physical activity, pre-COVID infection, but now healed? Have you experienced, now we're talking of the current management, have you experienced any of this?
Thank you very much. Exercise is good for health, general body health. Exercise is good. Exercise is good for circulation. Sexual function is about mental state and circulation. So physical activity, aka exercise, is very good for proper mental health and maintaining good circulation. So it is good for erectile function. So the reverse, therefore, is also true. If one becomes sedentary, then your circulation is poor, therefore your sexual function is going to go down. COVID infection is a new one. We are only 1.5 years into COVID. Those who got COVID are probably still too terrified to engage in sexual intercourse. In fact, I only have one patient with erectile dysfunction, but I was seeing him before he got COVID infection. And once he recovered from COVID, he came back and continued with these medications. But I must say there is no data to directly say that post-COVID infection, this is the situation with ejaculation. Suffice it to say that there is growing evidence that COVID affects all areas of the body. So probably wait and see, and the literature is going to start coming out soon.
Asante Daktari on that. So members, for some of these questions, they seem to be repetitive. You'll allow me to, if I've not read out your question, it maybe probably have been answered in another way. Yeah. Doc, there's one on pressure. Does nutrition have a role in PE, Daktari?
Nutrition, general well-being, number one. Number two, of course, if one has predisposing factors, diabetes, for example, of course, one needs to be in a proper diet. Hypertension, one needs to be on a proper diet. So generally, nutrition will generally have a role. But again, it also brings us back to the question of should you have groundnuts, should you have pomegranate in your diet, and all that kind of stuff. So it takes us back to the issue of herbs and whether herbal remedies do work. Of course, if you're eating some of these herbal remedies but are said to work, then nutrition has a role.
Oh, thank you very much, Dr. Now that question answers the same question by Dr. Hakim Kiboi. We move on, Dr. Hakim. Can tachyphylaxis, Dr. Hakim is asking, can tachyphylaxis occur with dependence on the drugs mentioned?
That's for me or for Maina?
That is for you, Daktari.
My last pharmacology class was a long time ago, but if I try to remember, tachyphylaxis is one where somebody was reacting to something.
Let me get that for you right away. Tachyphylaxis, Daktari, is where rapidly diminishing response to successive doses of a drug, rendering it less effective.
Interesting question. When you look at these SSRIs, the ones on long-term dosing, daily dosing SSRIs, it has been shown that whereas the peak benefit is achieved at around 3 to 6 weeks or so, the benefit is also not lifelong. And if I remember well, I think it's indicated almost after around 3 years, then the benefits starts going down. So I think that answers that question. So the benefit from the medication starts going down. The question is whether this is a psychological issue or is actually an issue of drug ineffectiveness. The same has been shown with topical agents also, that over time, patients report failing to benefit from the intervention. No reasons have been given why, but it is thought that it is more of a psychological kind of problem, because then you get into a situation where psychologically you say your sexual function is medicine-based, and indeed your partner might also remind you that your sexual function is medicine-based. However, it has been shown in persons who have this particular condition are on pharmacotherapy. If they had psycho or sexology treatment as well, then they benefit from the intervention longer than those who did not have behavioral and psychological treatment as well. I hope that answers the question.
Absolutely, Dr. Probably from Dr. Peter Owino, comment on the effect long-term use of sildenafil and sildenafil. Does it cause dependency? Probably that is a question linked to tachyphylaxis. Men as young as 20-year-old are seeking and using these drugs rampantly. Your response, Dr.
You're saying men are using these drugs?
Yes. It says comment on the effect long-term of the long-term use of sildenafil and sildenafil. Does it cause dependency? Men as young as 20 years old are seeking and are using these drugs rampantly.
Okay, thank you very much. Certainly, the use of these drugs is a problem. Psychological dependence, definitely we are seeing psychological dependence, where one, because of performance anxiety, believes they must use the medication. So it is more an issue of psychogenic dependence because of performance anxiety. And really, what is the problem? The problem is expectations. Remember in one of the slides I talked about, you must understand the patient's sexual expectations. If you took Mina and I and asked us to last 20 minutes, you are probably killing us, right? But if you take a younger person and said, okay, I think we want you to last 20 minutes, then that probably is okay. So we need to be able to manage our sexual expectations. I mean, in the current young population, we have a lot of watching of pornographic material. I must say, in this pornographic material, there are two ways about it. There is a group of individuals who, after watching that material, is completely put off and cannot function. And then there's another group which is excited and function better. So in this group that gets excited and can function better, they want to be like that guy in the movie, okay? So performance pressure. So with that performance pressure, therefore, people tend to look for solutions which they do not necessarily need. And that is why also when you look at the classification of premature ejaculation, there's this group called subjective premature ejaculation. You are okay, but you think you are not okay. So of course, in such an individual, then we aim to manage the sexual expectations. That would solve the problem.
Asante, Daktari. So as we wind up our question and answer section, so I'm coming back to you, Mina. What is the cost from the supplier? Now, these are the retailers who are asking, and who are the major suppliers who have this dynamo delay?
Dynamo Delay is available with all the wholesalers. All the wholesalers in Nairobi, name them. The Nilas, the Transwise, Rangechem, all of them, Elder House, they have the product, and the cost is $14.90 trade price. 1,490, and as we said, that can last the patient for 3-4 months, depending on how many times the patient is intimate. But it has 270 sprays.
Oh, perfect, Dr. Amaina. Now, as we probably wind up, let me allow the last question from again an anonymous attendee, Dr. Ikol. Can you clarify what are the long-term problems of precoital masturbation as a method of managing PE?
I think I talked about masturbation earlier and the effects of masturbation on sexual health, where you look at gentle and idiosyncratic masturbation. And I talked about the dampening of the arousal process because of masturbation. Long term, if one has premature ejaculation that can be managed by precoital masturbation, we are also saying, therefore, that this particular person is also undergoing other remedies like behavioral treatment or psychotherapy and short-term pharmacotherapy. So you'll find with time, that person does not require to masturbate anymore. It does not require precoital masturbation anymore. So it is okay in the short term. In the long term, it has its own drawbacks. Like I had mentioned earlier, avid masturbators have a problem with erectile dysfunction and premature ejaculation, which is very, very difficult to manage. In fact, in my practice, when a young man comes and ED, typically a 28-year-old boy, a 28-year-old man, sorry, and the first thing he tells you, I've been masturbating a lot, almost 6 times a day since I was 16. Right, I almost sink on my seat because I know this is going to be a very difficult case to handle. So it is difficult when there is a lot of avid masturbation.
Okay, perfect. Well, perfectly well in order. So for members, kindly note that this webinar is being recorded. So you're going to have all these questions answered again on the webinar. It's going to be on display on the Pharmaceutical Society of Kenya YouTube page. That is PSK. As now we get the closing remarks, probably Dr. Patrick Miner, you can start with your closing remark.
All right, thank you very much. I would like to thank you, Dr. Gitau. I'd like to thank Dr. Ikol for a great lecture and information sharing, and all the members who are present today. Thank you for having time and also for giving us this opportunity to come and talk about a very important topic, and for us to say who we are. We are able to, we are everywhere in this country, we're able to reach everywhere. Maybe we don't reach everybody, but anybody can feel free to contact us. We can provide solutions wherever you are and whenever you need it. Thank you very much, and we'll work closely into the future.
Asante sana, thank you very much, Patrick. So probably we hope to see CC Pharmaceuticals in the conference coming up in October 26th. We're having the annual conference going to be in October from 27th to 29th. Asante. Dr. Ikol. Thank you. There's a very grave question here as you give your closing remarks. Is withdrawal method equals to masturbation?
Okay, thank you very much. Withdrawal is not equals to masturbation. I believe that is one of the techniques for family planning, which basically means ejaculate outside. So it is not the same because one is engaging in normal sexual intercourse, but when it comes to the time or to the point of ejaculation, then one has to pour outside. So that is not the same. On closing remarks, I must say thank you very much for having me with you. This is not an audience I have addressed before, but apart from those who are in class with me in the late 90s, where we shared our physiology and biochemistry classes, I don't see any one of them here. I've been looking through so that I can greet them. But Sisi, thank you very much for having me to make this presentation. You still haven't told me why you asked me to make it, but nonetheless, I thought maybe you thought I could deliver it well. I must say the audience has been very interesting. Looking at the participation of the audience and the questions asked in the chat box, this has definitely been a very interesting topic that you have sought to have some answers. It has been a pleasure to have you listening to me. I hope I was audible enough. And indeed, I must say I'll be happy to interact with you again. Thank you very much, moderator, for a job well done. Thank you and good night.
Asanteni sana. So probably, ladies and gentlemen, we have come to a close of our meeting today. For those asking for who want probably more information or not on the Dr.'s presentation, for those who joined us late, we are going to have this recording posted on our YouTube page, that is the Pharmaceutical Society of Kenya. Kindly look at it, look for it tomorrow by noon, it shall be uploaded. Asanteni sana for joining, for all our seniors who have joined. Also to inform you, Dr. Ikol and Patrick, majority of our members are seniors, members who joined the society probably in the 90s and early 2000s. So Dr. Ikol, one of your classmates, will be here with us. Now our members, Lisilobidi Hubudi, anasema kwamba sasa tumefika tamati la somo letu la leo, ila mimi sina mengi ila kuaga alamsiki. Nawapa salamu na nawapa pongezi kutoka kiongozi rais wa Society ya Kenya, ya the Pharmaceutical Society of Kenya, naye ni Dr. Louis Mashogu, na nawapa pongezi kutoka pia kwa mkurugenzi Dr. Daniela Munene. Muwe na jioni njema na muweze kusikiza ujumbe kwamba conference yetu itakuwa katika mwezi wa Oktoba 27 hadi 29. Jioni njema and alamsiki.
Alamsiki, let me also say that.
Good night.
All right. All right. Thank you, Maina. Thank you.
Welcome. Thank you, everyone. Thank you, Mr. Vitao, Dr. Ikol. Thank you.